Hi, everybody. Welcome to tonight's event. I really want to thank each of you for spending time with us. I'm Craig Norman, and I'm very excited to be the host for tonight's broadcast sponsored by Euclid Systems Corporation, the producers of Euclid Emerald and Euclid Max spherical and toric Ortho-K lens designs. A couple of housekeeping things before we get started. If you have any comments or notes that you would like to put in, please type them in on the Facebook page. We will try to answer those questions as we go through, and we'll try to make this as interactive as any of those questions really cause us to do so. Before we get started, I'd also like to make a comment, more of a disclosure than anything else, in that the opinions and views that we're talking about tonight are not necessarily those of Euclid System Corporation, but are instead of those of my guest, Dr. Jennifer Harthen, and myself only. And I'd like to, with that, go ahead and introduce our guest. Jennifer, if you don't mind, I'm just going to spend a second here and read a little bit about your bio. I know it personally, but I hope others can learn a little bit about you itself. Dr. Harthen is a graduate of Illinois College of Optometry, where she then stayed on and completed a residency in cornea and contact lenses as well at ICO, and then later became a full-time faculty member, which she is right now. She's a professor at ICO and chief of the Corneal Center for Clinical Excellence at the Illinois Eye Institute. She's been involved with numerous publications on topics of complex contact lens fits and anterior segment disease, and is actively involved in ocular disease and contact lens research. A real great honor to have you here tonight to discuss basically the topic of corneal topography, and hope that you can pass on those little hints to our audience. So before we move on, did I miss anything at all about your background?
No, I think you covered it. Thank you so much. I mean, that was pretty kind of you to say all those things, but no, I think you covered it. So
okay, so I should let the audience know that we're both from Minnesota. So when we talk funny, we're just communicating with each other.
We're speaking our own love language. Yes.
Excellent. Excellent. Excellent.
The longer the O's become.
For sure. And so by the end of the night, we'll think we're back in the Twin Cities, talking to each other. Right. So tonight's discussion is a really important one, and it's one I know that you have a definite level of expertise from, both clinically in the private practice setting, along with your teaching at the school and teaching in the clinic, and that is of corneal topography and tomography. And in particular, we want to discuss tonight about how those measurements are taken, when they're used. Are there differences in different age groups, for instance, and how the measurements are taken and so on? So I'd like to start with, just as an additional background, can you tell us a little bit about what your week is like? So that you have clinic, right? You have teaching, you have private practice.
That's a really good question. And my week kind of varies depending by the week and by the quarter, but the majority of my time is spent at ICO. I'm full-time there. I've been full-time ever since I completed my residency. And I spend most of my time in the cornea and contact lens clinic, whether that's working with students or residents, but that's where I spend the majority of my time. And then 2 quarters out of the year, I do teach classes. I teach one of the anterior seg classes, and then also the specialty contact lens course. So I do that. And then on Saturdays, I spend half a day on Saturday at a private practice. And I've been at this practice ever since I was a student. I did one of my extra rotations here, and then I just have stayed on part-time. And I think, it's important, to bring some of that clinical experience into the clinic at the college, just because they are different settings. But it's a lot of fun, and it keeps me on my toes, and I enjoy working with the students and the residents as we have to stay up to date on the new technology and what's latest in research, so that not only can we provide the best education to our students, but also for our patients.
It's terrific. I always felt that being in the clinic made me a better teacher or lecturer, and being a teacher or lecturer made me a better clinician. And so they both really fit in so handy, because you have to be on the top of your game, as you just mentioned.
Yeah.
So if we could start with, can you explain to the audience tonight the basic differences between corneal topography and tomography? Where are we at with that today?
So I think that's a really, really good question. And I often sometimes hear people use those two terms used interchangeably, and they are different. Topography is when we kind of just think of just kind of a general curvature of the front surface of the cornea. Think of that kind of like your placido rings. So it's just going to give us more kind of a general characteristic of the shape of the cornea. It's represented by color. So it is kind of a geographic map, but it really just gives us information about the front surface of the cornea. When we add in tomography, not only are we getting information about the front surface of the cornea, but we also have information now about the back surface of the cornea and also cornea thickness. So I think those are really kind of key points to differentiate that if we want more information, if we're looking at a patient maybe with more pathology, if we're doing maybe co-management as far as surgical co-management, I think, tomography might be more beneficial, or if we do more custom lens designs, the tomography might play more of a role because we can get further out into the corneal surface. But again, heard those terms used interchangeably by some, but there are some differences.
Sure. And I think most commonly what you hear is it's all called topography.
Right.
And although that there definitely are differences. So where does topography and tomography fit in the practice from the standpoint, you may not have a specific written protocol, or you might with the way that you handle each kinds of cases, maybe at the school or in the practice. But even if you don't, you have a protocol up here, the way that you follow and use each of these tests. So for contact lens wearers, are topography and or tomography always part of that protocol, or do you wait until you're working through the decision tree?
So if you would have asked me this question 5 years ago, I probably would have said I would have waited until maybe I have a patient who has higher astigmatism, or maybe their standard soft lens isn't fitting the way that it maybe should, and that could be because of their HVID. Maybe I'm not getting accurate measurements because we were doing more just regular keratometry. I remember that keratometry only measures that central 3 millimeters of the cornea. So that's really only about 8% of that entire corneal surface. So we're missing a lot of information about the rest of the cornea, specifically that peripheral cornea. So maybe 5 years ago, I would have said I maybe not be doing topography, tomography on every contact lens patient. Shifting gears now, I would say most contact lens patients doing topography and tomography. And I think it's just because we want to provide our patients with the best fitting lens so that they have the best visual outcomes. And I think that we can achieve that by incorporating topography, tomography into clinical practice. So
I think that's for sure well said. And I'm sensing from the way you put it that that's the same whether it's the private practice or at the school.
Yeah, so at the private practice, actually every single patient has a screening topography done. When they're a new patient, they have topography done. And part of that also is the patient population that we see. We see a lot of kids and teenagers, and we do a lot of myopia management at the private practice. So that's some of the information that we want. At the school, maybe some of our just straightforward contact lens fits, we may not be doing topography on every single patient, but when we have, that higher astigmatism, or perhaps, a lens may not be fitting, we are doing more of that more frequently.
So of those techniques, let's just talk about topography, if we will, as compared to tomography. Does one have an advantage in the area of Ortho-K versus the other?
Yeah, so I think what we want to look at is what is our goal, right? So what are we trying to achieve? And when we're talking about orthokeratology, we're looking at how the lens performs on the eye when the patient is sleeping. And how we're going to determine what's happening is by doing topography, tomography. You can achieve getting those results and looking at that with topography. But really, whatever instrument you're going to be using, you want to be consistent with that same instrument because your success and how the patient is doing is going to be based on your baseline scan. So I know that some practitioners have just topography, some practitioners just have tomography. And I don't think that you necessarily have to have every single type of instrument, but whatever instrument you do have, you want to be consistent with your measurements so that you can monitor these patients over time, because that's how you're going to determine, is the treatment working? Is the treatment decentered? How are you going to troubleshoot? So in terms of looking at the different types of scans to look at, looking at your tangential maps, looking at your elevation maps to determine how much astigmatism the patient has, how is the lens going to fit, how is it going to center, do I need more of a spherical design or a toric design, things like that.
Sure.
Some of the things that we look at. And then also obtaining a good quality scan at your baseline is so important no matter what instrument you're using. If you don't have a good quality baseline scan, then your results are going to be off.
Yeah. Yeah. Well, totally agree. You know that there are designs that don't necessitate topography as part of the fitting process. And, I think that the Euclid system products are a fine example of that. But they definitely need to have a baseline topography so you have something to match later on what the effect is.
Great.
Yeah. And so having, to your point, that accurate baseline is probably the most important thing, because you can't take that over again.
No.
You can only get the baseline once. And so when you don't get good images, do you use lubricants sometime for the eyes, or do you have any other little tips there if you're not getting the scans exactly the way you want them?
So, with your topography, with your placido-based scans, that's really based on tear film. You get a lot of reflection. So if you have poor quality scan, a low viscosity teardrop is helpful. When you're looking at your tomography, whether that's your Scheimpflug or your horizontal slit scan, or, your anterior seg OCT, that's not as dependent on, your tear film. So if you have somebody maybe who has poor ocular surface issues and you're going to be doing a scan, then maybe tomography is more beneficial than topography. But yeah, absolutely instilling a low viscosity teardrop, getting the lids out of the way. You can get a lot of shadows from the eyelids and eyelashes. That's beneficial. And I think overall, especially if we're doing this on kids, just making sure that they're comfortable. Kids sometimes can get a little bit apprehensive when they don't know what's going on. So reassuring them about what you're doing and just, guiding them along the way can help. And if you have a bad scan, then take multiple acquisitions so that you can try to find one scan that's going to be worthwhile in using.
Okay. That actually leads into the next question that I had for you tonight, and that is related to children and topography. Because in the Ortho-K world, there's so many kids that are involved in wearing these lenses. Let me start by saying, what is the youngest child you ever put into an Ortho-K lens?
The youngest that I put in was 5.
5. Okay. So how do you easily get a 5-year-old to sit still on the chin rest of a topographer for the length of time you need to do to be able to make the adequate measurements?
It's not easy. We all know that working with children is not the easiest, unless you're, a pediatric specialist, which I don't pretend to be. But I think, kids, they want to be in a safe and fun environment. So sometimes they also like to see what you're doing be demonstrated to them. So sometimes we'll have one of our staff or one of our students actually sit so that they can see it first. Having a good stable chair that doesn't swivel so that they're not moving around, or having the patient stand up, and then also holding their head in place, all works really well. We've also had kids sit on their parents' lap,
Yeah.
take scans as well. That's helpful. But a lot of it too is, some of them get a little bit timid and a little bit scared because it is a new thing. But, we also have like a big screen on the wall. And we're like, we're going to take your picture and then we're going to put you on TV. And do you want to see your pictures? And so I think just trying to make it more fun for them, and, showing them what you're doing, then they really get kind of excited about what's happening. And then they get excited for their follow-up exams as well.
Yeah, that's a really, really good tip. I always thought the part of the process that was most challenging for the child is when you force their head to stay in position, because they feel trapped.
Yeah.
And it's not a comfortable or expected feeling.
Right. It's not.
So
Some of it's too just the language that you use, having them hold on to the bars versus putting their head on is helpful. It's like, okay, I want you to hold on real tight, like you're riding your bike. Let's ride real fast. Or, you just have to try to make it fun for them. And
right.
having great staff and students, but I think it's also important for you to know how to use all the instruments yourself. That's helpful as well.
Sure. Yeah. Wow. And of course, you may have had this happen in the private practice. At some point, if the staff is having an issue getting a measurement, you might have to go in and take it yourself.
Right.
So you have to look like you know your way around the
Yes.
instrument to be able to accomplish that. So anything unusual about the topography process for adults, or that's pretty straightforward?
I think it could be the same thing, holding lids. Sometimes the two with adults, sometimes they have drier eyes. So that's something to note as well. Having them close their eyes and then opening them when you're ready to take the scan, but using those low viscosity tears is really beneficial as well.
Yeah. Okay, great. So, the unique thing about orthokeratology is that depending on the system that you use, you may only see the lenses on the patient's eye once or twice, right? And so, for instance, if it's a Euclid design that it is designed by nomogram, you would look at it on the dispensing visit, and then you would look at it possibly depending on if you wanted them in wearing the next day or not. And my point is that because of that, you're living and dying by the diagnostic skills of the map. Yes. Because you aren't actually seeing the lens as well as possible. So let's talk about the maps, for instance. So, you only take one measurement, and through the topographer, you can look at it in a number of different ways. So can you talk a little bit about where the axial map fits in? And then we'll talk a little bit about the other ones as well in just a moment.
The axial map, I think, is really beneficial in that it's kind of, I don't want to say a screener, but it kind of is. It kind of gives you just kind of the best optical characteristics of the cornea. It kind of gives you general representation of the contour, but I like to look at the axial map really to look at the astigmatism, the corneal astigmatism. Like, number one, is it regular or irregular? Is it with the rule? Is it against the rule? How much does the patient have? And then what's the location? Is it center? Is it just central, or is it limbus to limbus? And I think that's really important, especially if you're trying to determine, are you going to go with a spherical lens design, or if you need more toric curves incorporated to help not only correct the vision, but also to help with centration. So that's kind of how I use the axial map, that it doesn't necessarily give you detail about the cornea, but it gives you kind of this general representation. I think one of the downsides about the axial map, though, is that it kind of assumes that the apex of the cornea is at the center, right?
Exactly.
So that's, I think, where you have to be careful in just utilizing the axial map. And that's why it's important when we look at these printouts, why we have all these different maps, You just don't want to rely on the axial map, because if a lot of our patients, their apex are decentered, and we want to look at that because, again, that's going to affect centration. And sometimes no matter what we do, we're not going to achieve that perfect centration. So
Yeah.
those are some of the ways that I tend to look at the axial map.
Okay, so that brings up another point that I failed to ask you before. When you're trying to get the proper centration of the eye aligned with the instrument, do you have any little tricks there about looking from the center to another part of the ring pattern, for instance?
Yeah, and sometimes too, I'll even have the patient cover up an eye. Sometimes that's helpful to try to get as centered as possible. So sometimes I'll have them, look temporal, look nasal, and then look right at that center light. But sometimes if you're having a hard time trying to get centration, I will actually have them cover up one eye just to focus on the one. And
Yeah.
that's helpful too when you have some patients who have some binocular vision issues as well, when you're starting out with these fits.
Okay, great. Now I know that we talked a little bit about the axial map and trying to figure out the astigmatism, and there is another way to do that, of course, through looking at elevation differences as well.
Yep.
And I'm sensing that that's probably part of what you look at or teach.
Yeah. So I think kind of like the big maps that we look at, obviously, are the axial map, the tangential map. You have your elevation map, and then you also have your difference maps. I think those are kind of the maps that you kind of put together that picture, not only at your baseline and when you're trying to determine what lens is going to be best for your patient, but then also those maps specifically, kind of your elevation, difference, and tangential maps at follow-up and how the patient is performing and how the lenses are working.
Yeah, of course. We live and die by the difference or subtractive map,
Yep.
to be able to see exactly what the finished product is looking like. And so I think that that's an excellent tip as well. So what about forget the practical part of this. Well, let me say this first. One more question. So when you are looking at the map itself and you're trying to evaluate post-fit what the treatment zone is like on the cornea. So we're not talking about the lens now, we're talking about the cornea and the treatment zone. In your mind, when you look at the map, where does the treatment zone go from? Is it only the bullseye? Do you include the elevated area just adjacent to it that's underneath the reverse curve? Is it outside that, in your mind and how you teach it? What do you call the treatment zone?
The treatment zone is within kind of the red ring. That's kind of how we look at it. And that's going to, I think, change depending on, is the patient a low myope? Are they a high myope? Are they using this for myopia management and control versus myopia correction? So again, I think you have to look at what is your baseline and how is this being used, because not every map is going to look the same, and not every map is going to be perfect or textbook, and that's okay. It's knowing when is something not ideal or not best for that patient, and then when do I need to make a change from there.
Yeah.
Because not everything is going to look the same based on your initial starting point.
Right. And then, of course, there's the whole role it plays in the difference between children and adults. And
Correct.
for the adults, where you'd like a much larger treatment zone, and where the children, of course, you probably are more interested in a smaller one. So how about, let's forget the technical part as we start to get near the wrap up for this evening. But so what do you use the topography outputs for? Do you use them as a practice management tool for the parents, or do you talk about them with the kid? How is that?
So yes and no. So I do for most instances, but sometimes you have to be careful because some parents really want that perfect looking bullseye. And if it's not perfect, then they want to know why. And then that can lead this to this whole rabbit hole of conversation as to it's okay if it's not perfectly centered. They're still doing well. This is the goal. So use it as a teaching tool and practice management and saying, this is our starting point. This is where we are. This is the difference. This is working well. But sometimes I also have to be careful and pick and choose how much I show based on the patient that I have in the chair.
Yeah. Yeah. Or in more general, the parent.
Right.
Yeah, in that, and I know exactly what you're saying here too, that they can pick up little intricacies on a topographical map that topography experts can't pick up
Right.
as the parent, and they're asking why is it shifted this way or up or down, and it could be as simple as the child looking in a little different direction.
Or they slept a little differently, or when they took the lens off, it could have slipped a little bit. You know, the patient comes in seeing 20/20, they have no complaints, but something might just be a hair off. Well, do you think you need to change the lens? No, they're great.
Yeah, yeah. So do you think I've missed asking you anything? I mean, is there some little tidbit do you think that you should be sharing with the audience that with my inadequacies as a moderator I've missed?
Well, you were one of the best moderators, and I loved talking to you about anything. But I would just say, you know, really listen to the patient. You know, if they're not having any complaints and maybe the topography doesn't look perfect, well, so what? You know, maybe you don't have that perfectly centered treatment, but if they're 20/20-ish, they're doing well, and you're still getting that desired effect, leave it alone. Whereas if maybe they are complaining, maybe they're having glare or they're having discomfort, and then you see that the treatment is decentered, well, then maybe you need to make an adjustment. So I think making sure that what the patient is telling you and what you're seeing, they sort of correlate. And then also, you know, make sure that you're not making adjustments too soon. Using those maps, you know, give it some time. How a map looks at day one is going to look different at, you know, 1 month. So just give it some time. And patients overall usually do pretty well.
Yeah.
Those would be my little kind of pearls.
Right. Well, those are very, very important tips. And I think that, you know, you covered all of this excellently tonight in a very short period of time on this topic, to be able to go all the way from the differences in the instruments to how you would use them, where the protocol might fit in related to them, what the different maps are like, how you handle it with kids, you know, as far as their measurements and so on. And so I think it really a very educational and interesting pieces of information you've supplied to us tonight. And I really appreciate your time.
Thanks, Craig. I'm happy to be here. And again, thank you. It's always great talking with you. And I've learned as much from you. So thank you.
Thank you. This is part of that Minnesota Love Fest again. So I like it a lot. So, yeah. And so anyways, I'd really like to thank Euclid System for sponsoring this event. But it appears we have one additional question coming in. And before we close that out, I would like to be able to answer that if possible. Here's a question that you'll have to help me with. What do you think about the all-in-one units like the VX650?
You know, that's a really good question. And I think that it could make it a lot easier for our particular young patients to take some of these acquisitions where you're not having to take multiple, you know, scans on different instruments. I personally don't have a lot of experience with them yet, but I think that it could do a lot of good, especially for young patients.
So the VX650, is that the Visionics?
I think so.
And so the all-in-one, do you know in that particular unit what else is there? Is it automated Ks along with topography and refraction.
Topography, refraction, and then IOL as well.
Okay.
So axial
Okay.
length. Axial length.
Okay. All right. So that's a fairly new unit.
Yep.
Okay, that is terrific. So again, then in closing, I want to thank Euclid for sponsoring tonight's event. And please, if anybody has any additional questions, or if you're viewing this after it is on live, please send some comments in there. I'm sure that, and questions that Dr. Harthen would be glad to answer them on anything that you might have. I'd also like to mention that if you join us again on Thursday, October 21st, Dr. Catherine Richdale from the University of Houston College of Optometry will be with us. She has some really interesting discussion points related to patient agreements and patient brochures as a way of solidifying the communication with the patient, which I guess, Jen, is just another piece of this puzzle, right?
It is.
To be able to make that happen.
It's a very important piece of the puzzle. So
For sure. So once again, thank you so much. It's great to have you here as a guest. It's great to have you as a friend and a colleague. And I can't think of a better way, at least for me, to spend an evening. Thank you.
Thank you.
Okay. Bye, everybody.